you wish to ask a question, please stick your hand up or write it into the chat bar. Okay, so Rima, I'm just going to hand straight over to you, if that's all right.
Yeah, thank you very much, and happy Friday to you all. I have a few things that I wanted to mention, and then I could open it up just to questions like I usually do on this monthly meeting. So a few updates. The first one is around CCPL. So that process was a kind of a month's long consultation, and that's now ended. That ended on the 31st of May. It's going to take a little bit of time for them, for Nell HR team to work through the outcomes of that consultation because they've got to do it for all 7 boroughs. We've also had some dispute in terms of BMA about the consultation papers and about some of the timelines that were written in there. So HR are just working through that. Once that's resolved, then we can then release kind of the outcomes of the consultations. It's all still looking positive for Newham. I don't expect there to be any changes since the last time I spoke about it. And the good news is we should be able to go out to recruit for a couple of our roles. So one of them is the cardiovascular disease clinical role. I know Sharika was in that role and she's unfortunately stepping down. So we should be able to go to recruit for that, and also the cancer lead role, which Helen previously did. So we're just getting the JD put together again. We're probably going to use the JD is the same as last year. But then once I have the final date that we can go out to recruit, we'll send an email open to all primary care members. And just to remember, it's also open to allied health professionals as too. It's not just GP colleagues. So if you have anyone in mind, then please do, let them know. If they want to know more information, then they can contact me directly as well. I've already had a few, so that's really good. So I'm hoping to kind of get those roles into post very soon. The other thing I wanted to mention is around ELF and the rapid response. Now, I know many of you had raised concerns about the long waits from getting through to the rapid response team. Before they used to accept the paper referrals and then it switched to telephone. So it's taken quite a lot, but we've got somewhere. So now they've got a dedicated option 3. So if you call the number on the SPA form, they have now produced a dedicated line. So that's option 3, which will then go directly to the rapid response nurses. So we don't have to wait on the call. I have tried that recently, and they're very quick at picking up the phone number now. So please, can you let me know if you're still having any issues, because then I can feed that back. But if I don't hear from you, then I presume that is now working fine. The other thing was Shrewsbury Road is now open to x-rays. So I know that was kind of put on the WhatsApp group a couple of weeks ago, but I just want to remind everyone that that's now open as another option to refer patients for x-rays rather than Newham Hospital. Obviously, they are extremely busy there. So if there's anything like chest x-rays, it can just, if the patients are happy to go to Shrewsbury Road, that's good. And the last thing I wanted to mention is Zena Etheridge, who was our chief exec of North East London, came to Newham on Wednesday, and she came to visit 2 PCNs that were hosted by Rahana and Carolyn. And I have to just say on this call, thank you to both of them and all their staff at the practice. It was really insightful. I think they did very well in articulating kind of what's going well and the challenges. And I think Zena walked away sort of really realising our issues around estates is a massive thing, and also around workforce and retention of kind of our staff as well. So those are kind of the main highlights. But I just wanted to say formally today, thank you to both of them. It's not easy when we, to arrange these things, especially in general practice when it's so busy. But thank you to them both and the staff. So those are the main things from me. But yes, open it up to any questions. Laura, hi Laura.
Hi, Remy, you're right.
I'm
It's just
good.
a quick one. You might have missed
Yeah.
it on the WhatsApp. I sent a message a few weeks ago about
Okay.
the things that keep on happening with Newham Lab, that they keep on having these episodes of either results not coming back because they've been left too long, or loads of duplicates.
Yeah.
And obviously, I've raised it with you before, and you go back to
Mm.
them and they go, yes, we're very sorry. We will make sure that we do communicate when there is a problem again in good time. And this has happened at least 6 times.
Mhm.
and it doesn't change. And so they have acknowledged that they do recognize when there's an issue, but what they are not doing is communicating it with us. So how do we escalate it? We can't keep on doing the same thing because this is so much workload for us.
I know. Okay. I mean, obviously, I'll have to go back to them. I'm escalating it to the highest people in kind of within diagnostics, and Nella are also aware of it. But again, you're right. If we're not seeing any change, then we've just got to keep putting the pressure on. Are you seeing any because they asked me, are there specific tests that we're seeing duplicates on?
From memory, I think it was Usinese last time.
Yeah, so I think it used to be B12 and folate, but they've managed to sort that out because I'm certainly seeing less duplicates in B12 and folate results. They also had that issue where they weren't able to process them for a short while of time. But the Usinese, and I'm also seeing obviously duplicates of patients having investigations done in A&E, and then the results come to us like 1 or 2 weeks later with kind of fracture or something. So I have fed that back to Dr. Hussein, who's the consultant radiologist at NUH, and they're going to look into that because there have been some duplicates from the images section. But I will take that back, Laura. That's all I think I can do, and keep putting the pressure on and see what they can do. I think it's just the way they are processing it, and then different people are then inputting it on. So not even recognizing that it's a duplicate, if that makes sense. But I will take that back. Thank you.
Thanks.
Rima, can I just add one thing? So the other thing that I've noticed is that we're getting results back. So there's not a result, but it will just be a comment, check in error, please ignore. But then why are we being sent that? Because obviously that still takes up 30 seconds or whatever. So if you're getting 10 of those a day, instead of processing results, we're looking at entries into patient records that we're asking to ignore them, basically. So I think that's something where it might be that when they're checking in the result, they're sending something to the GP when it doesn't need to be sent, which I think is a quick fix, I think.
Okay. That's a point of check-in, is it?
But it looks like that. I can find an example if that helps.
So there's no result on it. It's just acknowledging the GP that they've got the sample.
It will just say, yeah.
Yeah.
So it will say urine ACR, and then underneath the comment is check-in error, please ignore.
Okay, I'll take that back. That's hopefully something that they can sort out quite quickly.
And then another one that we get is, so again, I think it happens quite a bit with the urines. It will say sample too old to process, and then 2 or 3 days later, you get the result for whatever that sample was.
Okay, so you're getting kind of twice, but one to let you know that they've got it, and the second one, the actual result.
Yeah. And then the issue here is where the patient can see it, they call up and say, oh, was there a problem with my sample? Do I need to do it again? Sometimes you might give so it's just a little bit, needs a bit of tidying up, I think.
Yeah. Okay, I'll take that back. Is that mainly a Newham issue? You're seeing it? I mean, it's going to be mainly Newham. It's not going to be really Royal London.
It happens a lot for the urines.
Yeah. Okay. Right, I'll take that back. Thank you. Charles, did you want to come in on any of this? Do you want to introduce yourself, Charles, actually, first?
Okay, yes, I'll introduce myself and then I'll join this particular conversation, really to make a suggestion. So my name's Charles Guttridge. I'm the Chief Clinical Information Officer for Barts Health. But as you can tell by looking at me, I've been around for a very long time. And actually, many years ago, I used to be the medical director at Newham, and used to join this session, but physically in person in the academic centre at Newham Hospital. Anyway, we no longer do that. We do it online, and that's very nice and very convenient. All I was going to suggest, Rima, is that maybe you also kind of summarise some of those problems that you're getting from pathology resulting to you to Tom Butler, who is the clinical director. He's based at the Royal London, but he in essence has overall responsibility for this kind of communication. So I'd have thought just alerting Tom to that range of issues, some of which may be fixable. Some of them, I think, may be more difficult to fix. So, for example, the one that you mentioned about check-in errors and so on, those will be part of a sort of wider result, and the integration engine will just find everything and chuck everything at you. It may be possible to adjust the way the integration engine goes. I just don't know, but we certainly won't know unless you tell them. So, as I say, as well as having that nice contact with the pathologists at Newham, I would encourage you to just let Tom know.
Thanks, Charles. I have escalated it all to him as well previously, so thank you for that. I will once again do the same, but thanks for the reminder. Okay, anything else from anyone?
I just wanted to tell Rima about Charles. He just made me tearful after seeing him for probably 15 years. He was our medical director in the hospital, and he was extremely GP friendly. We always used to know that the most handsome and the tallest consultant in the building, and everybody wanted to do his farm. I can remember those days, Charles. Janet Medway, you've been there, Ellen, Colin Ainley, where those days are gone now.
Thanks a bit. Anil.
Just to add to that, Dr. Carl Guthrie, thank you so much for creating the primary care department at Barts, one of the first in Europe. Unfortunately, when you left and the new medical director came, he closed the department down, didn't feel that primary care was necessary in a hospital setting. So right now we have no primary care clinicians across Barts, which is one of the biggest footprints in Europe. But thank you to your leadership that we did have that department, and a team of myself, Sabir, worked under you and had great relationships. So before you do retire, please see if you can at some level try and influence that GPs are needed. We do need them at Barts Hospital. So those clinicians can work really closely with us. The interface has really, really deteriorated over the years. But thank you for your leadership.
All very kind comments, and I'll take as many of them away as I can.
So I don't think any more questions are up now for me.
Okay, I think, Anil, you've got your hand back up again, or is it from before?
Oh, legacy.
Okay, so just, and I think I'll just mention it now so that if we don't have time later. So there was the LMC roadshow yesterday. So I don't know if anybody went and had anything that they quickly wanted to share, any key thoughts or key highlights. Thanks, Laura.
Yeah, hiya. Yeah, I went for the LMC, and I've got a load of screenshots and some notes, so I'm just trying to put them all together. And I will send it through to all the other LMC reps who might want to share it with their practices as well. But really, take home was we really do need to be incredibly mindful about what we are doing, what is core, and otherwise, we're not going to be sustainable. And there are some key 12 areas that they've put together that we should really, really think about as practices about changing. You could do the whole lot. You could say we're going to do all of this stuff to really, really make these changes. Or you could choose to go slowly, softly and build them in, but it's incredibly important. And this is the only real way that we're going to be able to sort of advocate for our patients and for ourselves moving forward. But, an interesting point was, patient satisfaction is not necessarily about how many appointments that you offer. They've done a lot of research on that. I think people have to remember that. But I think a lot of it is about comms to patients and making them understand that we are on their side, we are there for them, and changing that narrative. And the BMA have produced lots of new comms. So I will send that out as well. In terms of comms that you put on your website, but also, so the blue comms is for the patients, the orange comms is for us in terms of what we're trying to do to make changes. So I'll try and include all of that as well.
Brilliant, thanks, Laura.
You're welcome.
Just one other thing I just wanted to mention, I'll mention it here in case, Rima, if anybody needs to ask anything. So practices that are opted in to deliver their out-of-hours care would have received an email asking them to clarify whether they still wanted to remain opted in and who their current provider was. So there's an email that was sent out with a deadline of the 12th of June. So just to make practices aware that that deadline has been extended to the end of the month. And I think that there's been sort of a few queries. So I think some people have gone to LMC with the contract that their current provider has been offering. I think some people have been looking for other providers. So I think some people have come to NHC, some people are going to PELC. So I think there's lots of conversations going on. So it was I just wanted to highlight that here, just to say that if you need any help or advice, please do. You can speak to Rima. If you think NHC can help with anything, please contact Karen, or if there's anything myself or Nadeem can do, please do reach out. But it was just to remind everybody that that deadline has been extended to the end of the month, so don't feel any pressure, because I think they gave us a bit of a short time span in which to look at this.
And just to add up, now I don't think the intention was for practices to then go out to find another provider. I don't think that was the intention. Obviously, I think it's been more for Nell actually just to find out that information, because Newham is quite unique in where we have the opted in and opted out compared to other boroughs. So I think they needed to kind of clarify where all the practices are at the moment, and whether they wanted to basically remain opted in or out at the moment. So I think that's where, but not for kind of practices to feel like any anxiety about it, that they need to, to go out and change things. So I did speak to Will briefly about this on Wednesday when he came to Newham. So obviously the primary care team are there as well, in terms of commissioners who are actually the ones who sent out the letter. So if anyone does want any advice to talk to, then obviously I'm here, but I can also signpost you to Will and Layla, who'd be more than happy to kind of speak to you as well in a bit more detail. But I don't want, practices to feel that, anxious about this at all.
Thanks, Rima. And I think, as I mentioned earlier, the LMC are looking at this as well for us. So we've got that support as well.
Yeah, perfect.
Okay, good. Any other question for Rima? Anything to let her know? No? Okay, so we'll move on to the next item on the agenda. So we're going to be talking about Patient Knows Best. And we've got Charles and Faisal that are going to be talking about this. And I think, so I've signed up to this to see what it was about, and I think it's going to be very helpful to patients as well as us GP colleagues.
So is that the signal for me to take
please.
over?
Take over, please.
That's great. I don't actually have the slides, so it would be great if somebody could work them through for me. I've done my introduction. I'll introduce Faisal, who is our outpatient program manager, but as part of that suite of responsibilities, he's also the project manager for Patients Know Best. You may or may not know that Patients Know Best was procured by the ICB about 3 years ago. And I'll talk through what it does, but the contract is held by the ICB, and basically any provider in ICB, in the NEL ICB, can use Patients Know Best to communicate information to to patients. And we started doing that at Barts Health about, it's now nearly 18 months actually. And I'll talk through the sort of things that we currently do. Patients Know Best is a private company. It, however, has integrated its software with the NHS app. And most people who have an account in East London access the app, access Patients Know Best through the NHS app. But it is possible to download an application from PKB and to use that directly. But as I say, in East London, most people use the NHS app. And I think that's one of the nice uses, because it means that things like prescribing and so on, which you can do through the NHS app, you can do it all in one zone as a patient. So as I say, we went live, I think, sort of March of last year, something like that. And we started by sending patients the appointments that they were due to attend. So there was no retrospective uploading of previous appointments, but any new appointments, if you had an account, would appear in the app for you to look at as a patient, plus an alert in your email saying there's a message for you, please have a look. That seemed to go well. Patients obviously had to make accounts. We inherited about 50,000 patients who already had accounts because other parts of London were already using PKB, particularly in West London. And one of the things you probably ought to know is that Faisal came from Imperial, where he had already been the project manager for PKB. So we were able to sort of go quite quickly because of his previous knowledge and so on. Homerton are also part of the hospital system that is uploading information, and the hospitals at BHRUT, at Barking, Havering, and so on are also beginning to do that. But I think it's fair to say that Bart's Health is far ahead of the pack. And where we've got to now is that patients are also getting inpatient discharge summaries. They get discharge summaries from their attendances at the emergency department and clinical letters. So letters that we write from the clinic also are sent to the PKB account. And then in the early spring, sort of January, February time, we started uploading laboratory results. And last week we started sending radiology appointments. So if a patient has been requested to have a CT scan, an MRI scan, an ultrasound, whatever kind of imaging. I think it is all imaging, but Faisal can correct me if there are one or two that we're not currently doing. And so those are being sent to patients, and we hope that that will reduce the number of patients who don't attend. But the really nice feature of this is in about 2 weeks' time, we'll start sending them their radiology reports or their imaging reports as well as part of the bundle. I think if you go to the next slide, so I think there are lots of benefits around this, but there are obviously some important caveats. The benefits, I think, and I speak here partly as a user myself, but being able to find information about yourself and manage your sort of pathway through the hospitals and so on, I think is a massive benefit for the individual patient. I think from the hospital point of view, and I hope from primary care, what we'll see over time is a reduced administrative burden, with less patients phoning up to say, what happened to that appointment? What happened to this? What happened to that? Because they'll be able to, well, they can log online and find that information out. Obviously, that's a bit of a trade-off. So the advantages of quick access to the patient about the administration of health is then more complicated because we're sending them results about their health, and that may generate queries both to our own staff and obviously to you as general practitioners saying, well, I've got this full blood count result and it says my white cell count is a bit low. What on earth does that mean? And does it mean I have leukemia? And those kind of questions. And I would put it to you, but obviously this is part of the debate, part of the getting used to these new processes, is it is obviously important for a patient to know that their white cell count is low. It's important to know whether there are any other tests that they should have. And that might be a reasonable question for a patient to come back and say to you, well, I went online and I looked up the causes of a low white blood count, and leukemia is one of them, but I'm more worried that I've got SLE because my joints hurt and I've got this funny rash. Those kind of discussions, I think, are healthy, but I can fully sympathize with your view that that may be an addition to your workloads. So we're particularly, I think, aware of all of that. Do you want to just show the next slide? Because I think that next slide sort of talks a bit about all of this. Yeah, so I think we hope we've put in sufficient support for a patient to phone up our help desk, which Faisal helps to manage, and to point the patients to the right clinician to answer questions. You won't be surprised to hear that we've had a bit of debate, and sometimes quite cross debate, with some of our staff saying, well, nobody told us, and this is extra work for me, and so on and so forth. In reality, I think it's fair to say that the number of patients calling us and asking for additional information is manageable in our view, and obviously we don't know what kind of effects yet that is happening in primary care. But as I try to sort of make out, I think there is a balance here of reduced administrative queries that may be taking up your time, traded off against perhaps a bit more engagement about what does this result mean and so on. But we hope that we've put in sufficient support in the hospital to take the sharp bite of that out for you. There are some other issues around providing, obviously, data to patients directly. One is around safeguarding. At the moment, we don't yet allow children to make PKB accounts, and I suppose it's mostly children who need safeguarding, and where results or letters in particular about safeguarding issues ending up in a mum or a dad's hand who's abusing the child might be very challenging indeed. So we're kind of particularly with the leadership at Homerton, working through those issues about safeguarding and at what age it might be reasonable for a child to make an account. And we'd love to hear your views about that, because I do see the development of PKB as a kind of joint enterprise right across primary care, mental health care, hospital care, and so on. And I think the same sort of safeguarding issues apply to older patients, particularly those with learning difficulties or those with great age who are losing their competence as individuals. So it might be worth me just saying, where have we got to? So about 150,000 patients in East London have made an account. I don't need to tell you because you see them all. There are many more than 150,000 patients in East London. If you include BHRUT, it's probably close to 2.5 million. And I have no idea if we'll ever get to that number of accounts, but patients are making accounts at the pace of about 2,000 to 5,000 a week at the moment, and we have campaigns every now and then to try and encourage people to do that. And I think some of the opportunities that are coming, which we haven't yet enacted, but is allowing or encouraging two-way communication between a patient and their hospital physician. So that might start, for example, by sending a questionnaire to a patient to say, we did an operation last month, we replaced your knee, can you tell us how much pain you've got in the knee, whether you're walking all right, and to use those kind of ways, getting feedback about the effectiveness of an intervention using online means. And certainly our orthopedic surgeons are very interested in that kind of thing. There's some some use of questionnaires already based at Homerton for patients with severe mental health disorders, and where there's a two-way communication around mental health that seems to be well received by both the patients and those attempting to look after them. And we can see all sorts of other uses as the software develops and as it currently is. So if you have either suggestions or ideas about how you might wish to use PKB, or advice from either me or Gareth Parks, who is a gastroenterologist at the Royal London, who chairs our committee, or Faisal, we'd love to hear from you. And I probably should shut up now and let you guys ask some questions.
Thanks so much, Charles. So we have got some questions. So James.
Yeah, I've got a couple of issues that you may not realise with these. So unfortunately, I've had to see the oncologist. I've got a close family member who's unwell, and there are some issues with this because some of the results are coming through on the system to patients before they've even been discussed with an oncologist. So, I mean, I would be quite concerned if there's no sort of vetting of how the information comes on, because we were actually advised to uninstall the app because the information coming through were results of the radiological results hadn't come through, but this is all coming through before it's been discussed in a clinic setting, which, I mean, even for medically minded patients, it can be quite distressing to receive a radiology report that says you've got a malignant mass when you've not had it in the proper environment to discuss that. And some of the oncologists are actually advising the patients to uninstall this app because the information comes through before they get to discuss it with them.
Thanks, James. So I think that's a great point. The rules around how we upload laboratory data and histopathology reports and so on, I think are clearly set out, but there is definitely the risk of what you've just described. So the rule is that histopathology and a range of tests that have been predefined, we don't report them up into the until 28 days has passed, in order to give individual clinicians a chance to either have seen the patient or contacted the patient and to explain the meaning of the result. That, of course, requires our staff to be using the sort of features of our electronic health record, just like you guys do in EMIS, which is to look at results, endorse them, and then talk to somebody if the results markedly abnormal. You won't be surprised to hear that not all clinicians are perfect at checking and endorsing their results, and so I think there is a bit of risk around this. I think
that's not happening. So significant results are coming through relatively soon after the tests have been done, and it's not 28 days afterwards. It's much sooner than that.
Well, so it depends what the test is. So histopathology is definitely 28 days. A blood count, for example, does come back immediately because we think that's important. And I think it's important for oncology patients as it is for patients without an oncology diagnosis. But if you're getting chemotherapy, and particularly if you've got a lymphoma or a leukemia, obviously the appearance of either blasts or a very low white count may indicate progression of the disease in a way that isn't necessarily expected. So I think there are some issues there.
I mean,
Yeah,
sorry, I'm talking about genetic results after cancer screening and genetic screening of tumours.
Okay. Well, we'll take that away and make sure that genetic screening does have the 28 delay in it, because I think you're right. I'm pretty sure that we do have the 28 delay against genetic tests, but there may be some which my comment earlier about the integration engine, obviously all of this, of the way it works, is all rules based. So we think we've got a comprehensive list of things that might cause distress without support of a professional advising and so on. But if things are missing or getting through because we haven't set that rule, then we can put in new rules for additional tests or other tests, more or less at any time. So I guess, James, because if you have a family member and this has particularly affected you, just dropping a note either to me or to Faisal saying, hey, this one did get through and I think this had impact in a way that we didn't expect, that would be great.
It might be worth speaking to the oncology consultants at Barts, because they're routinely telling patients to uninstall this because the information comes through too quickly and it's distressing their patient. So it's not just me and my my family who are involved. It seems to be a bit more systemic.
So I would say two things. The first is just to say that Faisal and Gareth actually did have a full audit session with the oncologists, and in general, I think we got agreement and engagement in the idea that this was a sort of next step in good practice in medicine, and so on. I would also put it to us that we're in a sort of period of transition around care where the empowerment of the patient is taking a really different model to the one certainly I was brought up, where you basically didn't tell anybody about anything until the last possible moment. And I think society is changing and the way we engage with this is changing, but we're all learning as we go. And as I say, we want to hear from you, and we get feedback, and we will specifically go back to the oncologists and get further views from them about how it's working. As I said, we're about to send radiology reports, and we know that our radiologists are anxious about patients seeing unexpected findings. For example, I don't know, a pulmonary nodule on a chest x-ray, and making assumptions about that. The radiology will have the 28 delay for sure, but I think it is possible for unexpected findings to sneak in, because they're often the cause of serious incidents because they're not identified by the clinicians early enough. I think in some ways our approach here with PKB makes that safer, because a patient will say, hey, what about that nodule? What does it mean? And come back to us. What I'm particularly, I think, keen to make sure is that the bulk of those queries are undertaken and dealt with by the hospital staff rather than you as general practitioners, for two reasons. One is you all work hard enough anyway, and secondly, you will almost certainly want to take advice from a consultant saying, what does that pulmonary nodule mean? And so we need to make sure that our staff are dealing with the queries. And that, I would say, is still a work in progress, to make sure that people are taking responsibility for the tests they order.
Thanks, Charles. So I think Laura wanted to come in. Laura, you've got a minute, please.
Yeah, no, literally, Dr. Guttridge, you actually sort of answered my question at the very end, because it is a very important point in terms of the hospital staff, and also the design of PKB has to show the patient that if, for example, hospital requested bloods or investigations have to go back to the hospital consultants. It's an incredibly important part of it. I'm the clinical lead for NHS App in North East London, so I work directly with them, and I'm still trying to get that point across. But if we can do everything in the design of it to make sure that happens, that will help. Thank you.
Yeah. Great point, and absolutely. And as I say, we are thinking about this really all the time with other clinicians, and getting feedback, getting thoughts, and I hope improving the software all the time. I think personally, I still think for East London, the challenge is still getting more patients to download the app and use it, so that some of those safety elements that I was talking about are really developed. And there's one thing that we know, because we've looked at this data already, but there is inequity already built into the solution. So we know that the patients who are using PKB on the whole are the middle class population of East London. They're the ones who live, in the Isle of Dogs, in the fancy parts of Mile End and so on. And for example, the number of patients who've created PKB accounts in Newham is significantly lower than other parts of East London. And I think that's an issue for us to work with you and to work with population health experts and so on, to make sure that we're not building in systems that make the access to healthcare and the development of self-care even worse, because people who don't have either the resources to buy the software, the phones and tools that you need, or have the digital literacy to engage effectively in these kind of things. So that's a real society challenge. It's not just obviously for me and Faisal to sort out. I think that's for whole of East London to have a conversation about what we do.
Okay, great. Thanks so much, Charles. There's a few comments in the chat bar that it would be great if you could have a look at those, just a bit of feedback. And I think Faisal's put his email address in the chat bar. So, colleagues, if there's any questions or if you have any points to raise, please do reach out to Faisal to email him. Okay. Yeah. Thank you. Thanks so much.
Thank you.
Right. So, now we're moving on to the Omnes team, who have been helping us with the new ultrasound and cardiology imaging service. So we've got Patricia here, and we've got Ayinke. So over to you, and sorry for the delay, and thanks for patiently waiting.
That's fine. Thank you very much, Dr. Patel. Hi all, my name is Patricia Williams, and I'm the General Manager for the newly procured ultrasound and cardiology in TNW, and I'm here with my colleague Ayinke, who is the service manager. Ayinke will be talking through the presentation, then I will just give a brief intro. The ultrasound and cardiology services was newly procured, and we started in April. But we've been doing a similar service in BHR for the last 9 years, which is back in Irvine and Dagenham. We've been there for the last 9 years, and we've been delivering ultrasound and cardiology there. And we won the contract to deliver the same service in TNW, which is the Tower Hamlet, Newham, and Waltham Forest for the next 5 years, with an additional 3 years. But we only started in April, and we've been having some teething problem, and that's one of the reasons why we asked to come on this call, so we can talk about the service, and then we take any feedback or any suggestion that will help us improve the service. So I'll hand over to Ayinke just talk through the presentation, and then we'll take any questions.
Thank you, Pat. Thank you for having us. My name is Ayinke Mogoji.
We can have the slide, please, Dr. Patel.
Yeah.
Sorry, we're having a technical issue. Nana's going to help put the slides up.
Okay, that's fine. But we can just talk, Ayinke, you can just talk through for the sake of time.
Okay, that's fine. I think Pat has kind of given us an intro into what we do. Thank you very much for having that up. Yeah, as Pat mentioned, we're already in BHR offering this service, and we remain in BHR for the cardiology service. So we are still at BHR running the cardiology service. We are currently in TNW now, running the ultrasound and cardiology. As you would appreciate, for every new service, there's going to be that teething problem. Of course, we've had a lot of feedback from GP surgeries, from their patients as well, who have been using the service. At the moment, we are running clinics. The whole aim is to provide an appointment closer to patients' address or their place of abode. At the moment, the waiting time for our ultrasound is between 2 to 4 weeks. And for our cardiology service is between 4 to 6 weeks. And the reason being that we have to rely on monitors. We rely on patients to ensure that they return their monitors as they've been advised. But this is proving very challenging, as at the moment, we're already chasing patients to return a good number of the monitors. I can understand this because, again, even with the letters being sent to them, we'll need the support of GPs as well to remind their patient that when they send them for this appointment, they need to return 24 hours after to return the monitor back to clinic. So that's a bit of the challenge that we are having. And then reports are sent back to GPs within 2 working days. This is slightly different for the cardiology service, but we can definitely confirm that our ultrasound service, once they've been seen, the reports are going back to GP within 2 working days. The challenges with the cardiology where the monitor is involved is that we're only able to do this to get it reviewed when we get the monitor back. The data is downloaded and is sent for review. So that's a bit of challenge there when patient has been seen and the monitor hasn't been sent back. As the service is growing, of course, we intend to offer a weekend service. At the moment in BHR, which we've done for almost 10 years, I would say, we've been able to offer a Monday to Sunday appointment, giving patients the opportunity when they're not able to attend during the week, they have the option of coming into clinic over the weekend as well. And we're across the BHR site. Now, we're looking to offer to replicate this in TNW, but of course, this will depend on the number of referrals we grow to make that demand possible. Second slide, please. Thank you. We have, talking about the feedback, how to refer to Omnes. Our initial attempt was to go through via ERS, knowing that ERS is quite secure. There's a footprint. You refer a patient, you can check the progress. But again, the feedback from GP surgeries is just that it's very cumbersome. The administrative process, they are not able to deal with it, and we've listened. We have now opened an email address where we are able to receive referrals, and that's clearly indicated on this slide. We're also able to receive this via ERS, but if you choose to refer an appointment via email, we're happy to receive that as well. We have embedded on this slide as well how to refer to us, but again, this is no longer relevant as we're able to receive referrals via our email accounts. But the guidance is there. We're happy to provide that if you're struggling to refer to us on ARS. At the moment, these are the current sites that we've got. We're at Eastham, we're at Sir Ludwig, we're at St. Andrews, Forest Road Medical Center, Spitalfield, we're at Westbury Road, Excess Place, and Synod. We're also speaking to other sites, other GP surgeries as well, who are in the pipeline, and hopefully they'll be happy to host us on their sites. We're happy to take any questions at this point. If there's anything we could do to make things better, or you have any suggestions for us, we are more than happy to take them on. Thank you very much for your time.
Thank you both.
Thank you.
Is there any questions? So I have one question while everybody gets theirs together.
Yes,
so you know that your processing time when it's emailed and when it's done on the e-referral system, is it the same?
Yes, it's the same. When the referral go, we have 2 working days for us to accept a referral and then offer the patient an appointment. The difference between the ERS, when you refer them for cardiology, they have an appointment because they will be sitting on an appointment because it's a directly bookable service for cardiology. But when you refer for ultrasound, if you refer a patient, let me say today is Friday, we'll pick that up by Monday or latest Tuesday, and then we'll contact the patient and offer them an appointment. So it's the same process.
Okay, good. And then I've got one other question with regards to the report. So I have used the service and I found that it was quite good to use the e-referral system.
Yeah.
When we receive the reports back, so we get them via email, if I'm correct.
Correct. Yeah.
Can we look to see if you're able to have them sent so that it's integrated straight into the EMIS system is one thing. I don't know how that's an IT thing, so I don't know. I think that might be one thing that would improve, so it saves the administrator having to upload it onto our system. And the other thing is, so as I said, I've not had many reports back, but as a GP, one of the things that I always look for is a good quality report. So if there's something abnormal there, is it something that can be dealt with routinely? Is it urgent? Because some of the times we do get reports back where it just says, please consider GP review. But it's like, okay, the GP will look at that, but what's the advice from the interpreter in terms of how urgent is it and what is it that needs to be done? Just a bit of help in that sense.
Yeah, thank you very much for that feedback. We'll discuss that with the medical director to look at that. With regards to embedding the results to IMIS, we are using System 1 because I think that's another feedback that we got from Tower Hamlets to say if it's possible to put the report back, but we are using System 1, so I'm not sure. But that's something that I can take back because we have a GP surgery which is owned by Omnes as well, Porters Avenue. I know they use IMIS, so I can speak to our IT to see if that's something.
Sorry, Pat, I think you're frozen. Can you hear me? Is it just Pat? Okay, I'll take it from that. I think it's our internet. Yes, we'll feed that back to our medical director and see what they can potentially do. Yeah.
Okay,
If
good.
we've got any more questions, we'll take that.
Also, Jitu?
Hi, thank you, Afna. So, basically, some patients have fed back. They're finding it difficult to find their location, especially the Eastham Memorial Hospital. And once when a frail elderly patient was late by 5 minutes, 7 minutes, the clinician refused, and the bystander was in a bit of distress. That's number one. Number two, there don't seem to be a reception team to actually, welcome the patient or signpost them to the relevant area. So is that something that Omnis Healthcare would be looking to make the patient experience slightly improved as well, please? I know it's teething issue beginning, but it's been about 2-3 months now. So is that something Omnis Healthcare is looking into doing with regarding to signposting, the signage of the area, and also with regard to a reception team availability? Thank you.
Yeah, we already have some signages there at Eastham, but I think Eastham is one thing that we've already discussed with the ICB and with the building manager. It's one of the sites that not even with patients, even with our IT, when they go there to do some works, I think they are confusing Eastham with the Shoeburys. I think there's a building sharing the same address. So patients get confused. So what we are trying to do now, we are sending text messages. We are doing a reminder call to just give patient the correct description of where to go. Because we've added that to the letter, but most people don't read their appointment letter. So we are doing additional work to do reminder and text messages. And with regards to the reception, that's something that we are working on because we've had feedback from the GP surgery at Eastham and the same for our Forest Road, that our patients are going there to disturb them. So that's something that we are looking to consider because we are having a sonographer and an HCA there. So they will normally serve as the chaperone and the reception. But there are times they will be in the room and patient might need some kind of assistance. So it's something that we are looking to discuss in-house and see what we can do to provide that service.
Thank you, Patricia.
Yeah, thank you. You can see another hand.
I think no more questions for you, but I think that,
someone hand up there. I don't know. There's one more there.
Oh, sorry, it's Anil.
Anil's chat, yeah.
I think
Hold on.
our partner, sorry, there's
I've
Dr. Andrew Lee is also had
Yeah,
a question.
Yeah, sorry.
Sorry.
Yeah, my profile doesn't give my name. I'm the PCN clinical director, GP as well. I just want to follow up with the report for the 24-hour ECG. At the moment, it only tells us the what does it show. It doesn't give any recommendation at all. It doesn't even say is it normal, is it acceptable, does it need to be follow up, does it need to be referred. It doesn't indicate anything at all. Just to say there's a couple of topics or whatever. So I think we need just a little bit more better quality of the 24-hour ECG report. So if you could pass it on to your medical director or someone to look into that.
It's something that we can take back and discuss with our cardiologist, who's our clinical lead. But the thing is, it's a diagnostic service. I don't think that we have the service to give like a further advice.
Not actual advice, but at least to tell us, is it normal or is it abnormal?
All right, that's right.
Yeah.
I'll take that on board. If you can take the actions, please. I'll take that on board and I'll discuss with our clinical lead to see what we can do to add that to the reports. Yes, Anil. I think there's another question.
Oh, thank you, Dr. Andrew, for raising that, because that was one of my concerns, that it's not about diagnosis, but the interpretation. So as GPs, we're not all specialist cardiologists like Dr. Subir Sen, who can read the ECG even. We've got very basic skills in ECG interpretation. Some of us haven't been to med school now for 14, 15 years. We only see ECGs on the ad hoc occasion. So when that interpretation comes back, we need some basic things on there. So we can't accept just an ECG by itself. We do need some kind of wording on there. And also, when you do an ECG, the person who's doing the ECG within the service, I'm sure has to send it over to somebody to verify or to check or to see if it needs an acute admission to hospital. So that is being looked at. So it's a case of actually just writing a few comments on there of what it is. The other concern I have is just yesterday, I've got one of my physician associates who's written to me with a complaint regarding your service. A patient had a 24-hour blood pressure monitoring done 5 days ago. The blood pressure reading on the report was 273 over 180, which is extremely high and which would warrant admission to hospital on there. However, we didn't receive the paper report until yesterday afternoon. That patient has been with that blood pressure and left your services without any clinical intervention. The patient was phoned by the physician associate yesterday on the telephone and had stroke-like symptoms, and this was sent with a 999 call. So I will email this over to you to investigate, but I want to find out what is the actual pathway. I know we've mentioned it before, and Dr. Sen, if you want to come in here, there is no emergency pathway, or is there nothing in place where if a clinician is doing a blood pressure without reading, surely they would know that that's extremely elevated, not even just borderline?
With the blood pressure, if I can just come in before the doctor coming in, it's our HCA fitting the blood pressure monitor. The patient will take it home, bring it back 24 hours, then we'll download the report and we'll send the report back to the GP. And when the patient bring back the monitor, we have 2 working days to do that. And that's one of the one that I don't think we have any delay with, because we'll just do it right there. And some of those HCA are not clinically experienced to know when to flag it. So that's why that's one of the reason, but that's one of the report that we'll send back as soon as we get the monitor. So I will check if you can send me the details. I'll put my email address there. Send me the details. I will see what caused the delay. But we'll normally send within 48 hours.
And do you have a pathway where when you are interpreting and copying it from the machine onto the paper reports that you generate, and then you're looking to send it over, if there is an abnormal reading like that, is there any parameters you have as an organization where you need to pick up the phone to us as a practice to say, look, we've got a worry or concern, or you can contact the patient directly? Because I think there is been that gap in the example I have from yesterday.
We definitely do. We have that for ultrasound. We have that for the 24-hour ECG, the 12-lead ECG, and the echoes, because they are being done by specialists. So if there's any result that is urgent, they will send us an email and they will create an urgent taxon system on. For that one, we should send it the next working day. Then we'll send the letter, mark as urgent, and then we'll pick up the phone, speak to someone, tell them that this report is urgent, please let the GP know. So we have that process.
And that's in place for the 24-hour blood pressure as well?
Like I said, the blood pressure is done by an HCA, so they might not know if it's urgent. So we'll normally just send it. But that's another feedback that we can take on board to see if we can put some training in place, tell them that if you see a reading like this, please let us know so we can pass that on to the GP. But we'll normally send the report within 24 hours.
Perfect. And please do look at the HCA, because all our HCAs in primary care have and work within parameters. So if anything is abnormal, they'll straight away know whether to flag it. So I think they are skilled individuals too, and they're qualified.
That's very good point.
So they do know the parameters, but if the organization hasn't set anything for them, it's kind of not their fault as well. So please do have a look at it. Thank you.
That's very good. Thank you. We'll take that on board.
Thank you. And then Dr. Sen?
Yeah, thank you, Patricia and Nikki. I think this is a very, very good initiative, because providing those kind of diagnostic in the community, but everything cannot be right from the beginning. There is a room for improvement. I'm getting a lot of your referral coming to my service. So what I need to do, would you arrange a meeting between your medical team and our community team with me and Dr. Ranjan, and then we can develop a clinical protocol for the GPs. So designing green flag, yellow flag, and red flag. So please, if you can arrange a meeting between us, then as a clinician, we can decide. So you don't have to go through this question again.
All right. Thank you very much, Doctor. We'll do that.
Thanks, Dr. Fen.
Yeah.
Thanks, Patricia, and thanks, Ayinke, for joining us today.
Thank you.
Okay, so the next item on the agenda is
We'll drop off Dr. Patel.
okay, all right.
Okay, thank you very much. Thank you. Yeah.
Okay, so we've got Zethu here, who's from our Newham Memory Clinic, so from the diagnostic services. And if I can ask that if anybody's got any questions or queries, they can put them into the chat bar for Zethu. Is Zethu here?
I was going to say, it doesn't look like they are. They're due to be with us 5 minutes or so ago, but it doesn't look like they're online.
That's fine, no problem. Can we move on to the next item?
I was going to say,
could you, Nana, could you see if you can find them?
So Kiana, I don't know if Kiana's with us because she was due on in about 5 minutes.
I think she is. Yes, hi Kiana.
Hello, everyone.
You stopped a bit earlier.
Yes, of course, go ahead.
Okay, brilliant. So, Kiana's here as one of our public health officers from LBN, and she's going to be giving an immunisations update. So again, if you've got any questions, put them into the chat bar or please raise your hand. Okay, over to you, Kiana.
Thank you. Good afternoon, everyone. Happy Friday. I'm here to talk about immunisations, as was explained. My role as a public health officer oversees childhood immunisations and also infant feeding. I'm not here to tell you about the 3 diseases that you can see on the slides. I know I'm talking with the experts on this occasion, but just wanted to give you a bit of an overview in terms of what public health are focusing on in the frame in the case of pertussis, hepatitis A and MMR. So if we could start with the pertussis section, please. Data across the borough when comparing with London and England levels, we can see that similar to the rest of the country, we are seeing decreases in uptakes of pertussis or the DTaP vaccine. I'm not going to go through the exact figures here, but I hope that slides will be shared with the meeting afterwards so that you'll be able to go through at your own leisure rather than this being death by PowerPoint. But the main message that we were wanting to convey here is, as I'm sure you're all doing, please make sure that you're reminding pregnant patients and also patients that fall within the early years category, families with children under 5 that they would be eligible for the pertussis vaccine. If we go on to the next slide, this shows additional figures for the most recent year for the uptake of the prenatal pertussis vaccine. And as I've said, we are experiencing quite low uptake for pertussis at the moment. So it is just to highlight the situation with that. And then the next section is just to highlight again consideration for hepatitis A and also preparing for the summer holiday season with travel vaccinations coming up. The next slide shows how in Newham we've noticed a higher rate of infection for hepatitis A in comparison to other boroughs in northeast London. So with this in mind, the breakdown of those cases is on the next slide for further information in terms of contact tracing and also what has happened in terms of the declaration of clusters and outbreaks. And again, as I'm sure you are all aware, the emphasis here does need to be on vaccination and making sure that families prepare before they go abroad as well. The cost of vaccination and prevention is a lot lower for us than the cost of treating a case if somebody does contract hepatitis A. So that gives us some further information on the cases that we've had and also the associated costs. And again, on the next slide, there's the global epidemiology for hepatitis A in case of interest as well. And then finally for MMR, I'm not sure if Paul is on the meeting, but Public Health have been working with NHC to coordinate some MMR catch-up clinics happening across the borough for the rest of the summer. It's a really great opportunity that we've got here to work with community organisations. So we have organisations such as the Magpie Project and Starlight joining NHC for some of these sessions, just to make sure that we're reaching those groups that have not had their MMR. The data indicates that we have quite a large population of children who haven't had first or even second dose of MMR within the borough. So it's been great working with Paul and Asma and the rest of the NHC team in order to make sure that we get these catch-up clinics as well. And they will also be happening in coordination with catch-up clinics that Vaccination UK are having for school-age vaccinations. So we're thinking teenage vaccines like your HPV, MenACWY. So hopefully we can have that final push towards the end of the school term. I'll be sharing, I'm sure dates will be shared with GPs as soon as they're available. I don't have them just yet, but I'll be sharing them across education channels and communication channels with nurseries and children's centres as well. So if anyone has any questions about those, please let me know. I'm hoping that I've stuck to my 5 minutes there. It was a bit of a whistle-stop tour of just highlighting those three main vaccines as a point of discussion at the moment.
Thanks, Karen.
Thanks, Alpana and Kiana. One, to address the comment Sheetal in the chat, but also, so we'll put out the details of the NHC arrangements. As Kiana says, we're doing a number of outreach. We're also doing some call and recall for unregistered patients, and also just trying to support practices in terms of some of the gaps that have arisen. The roving team that are doing that outreach, Sheetal, are particularly expert in hesitancy. So they've spent quite a bit of time around COVID, around polio, and a whole range of IMS, supporting either vulnerable groups with serious mental health or learning disabilities, or the range of client groups that perhaps are a little bit more anxious in terms of uptake. So please do liaise, Sheetal, with our roving team if you've got patients that you think would benefit from that offer. We do a number of quiet clinics for people with autism, things of that nature, where the service just needs a little bit of a different approach.
Great, thanks for that, Karen. Can I just mention one thing with regards to the travel injections? So I know that across the borough, all of the practices deal with travel immunisations differently. So I believe our GMS contract is that we have to provide, there's a certain travel injections that we do have to provide, but I think it may be that the way that we're all doing it is different. So I think some of them, some practices give the prescription, some practices buy the vaccine. So I think we just need to look at what we're doing within each practice, so that we're all doing the appropriate thing and following current guidance with regards to that. I might ask our medicines management team if they've got any up-to-date information that they can share, because I know that we sometimes have patients coming in saying, oh, I'm going in a few days' time, and they're asking for the immunisation. So it's just a bit of clarity about what practices should be offering our patients. Do we have any other questions for Kiana? Oh, Anil?
Hi, Aparna. Maybe for the next session, we could do a small 5-minute update on the contract itself. Can you hear me?
Yeah.
With our GMS contract or PMS contract, we do have to offer travel advice and travel vaccination, but the vaccinations that you need to be given in primary care are limited to hepatitis A and typhoid and diphtheria, tetanus and polio. And cholera is another one that is in our contract but is very rare, and that one is a prescription only one. The other 3 vaccines you are supposed to either get it from Inform, which is the the diphtheria, tetanus and polio. The typhoid and Hep A you need to purchase yourself as a practice, or you can happily get a prescription from the pharmacy who can dispense it, and then it's up for the patient to get it administered either within your practice or potentially within your out of hours service or your extended hours or whatever contractual mechanisms you have. The contract specifies and does say you do not have to have it available the next day. It has to be a reasonable length of time. And generally, when the LMC has looked at this before, it's a 6-week window. So you need to give the practice 6 weeks notice to be able to do that travel risk assessment for you. If it needs it or done any earlier, then it's up for the individual traveling to seek advice from a private provider. And how you can support that as a practice is to give a copy of your current immunizations to the patient, who can take that with them to the private provider. So don't be duped to think that you need to do it and offer it the next day for your patient. That isn't the case. Does that make it a bit more easier?
No, that does. And I think that one of the things that would be useful is to have some sort of written statement or something from LMC that practices could perhaps put on their websites, because I know at certain times of year practices are given a hard time when we've got patients that are due to travel asking for the injections with a short notice period.
And despite being the vice chair of the LMC is not always fit for purpose. And then this is an example where it isn't, where they would not give you out a statement. They'll say it's up for you to interpret the contract as you see with their guidance. And their guidance is what I'm telling you today. So happily for Newham, potentially our lovely federation could put together something and we could use it, or each practice could actually happily just do it themselves and say, as a practice, you feel 6 weeks is a reasonable time, which is what we've got on our website, for example. But in the meantime, if you need to travel urgently, we'll happily give you a copy of your current immunizations and seek private provider to get them done. Your yellow fevers, your other ones they're not available in general practice generally, unless we've got yellow fever centres. And in Newham, I don't think there is any practice left now that does yellow fever because of the litigation and all the other new bureaucracy involved. That's all been taken away now.
Great, thanks Anil, thanks for that. Just one other point with regards to the whooping cough vaccine. I think from the 1st of July, the vaccine that's going to be given or should be given to pregnant women has been changed. So it's no longer Boostrix IPV. So I think the new vaccine, I can't remember the name, but the new vaccine is available to order on Inform. So from the 1st of July, the vaccine that we're giving, the pertussis vaccine we're giving to pregnant women, is different. It still remains Boostrix IPV for children. Any other questions for Kiana? Oh, I can see a hand. Sorry. Oh no, sorry, it's still Anil's. Okay, so thanks, Kiana, and I can see you've shared some useful information in the chat bar as well, so thank you for that. I'm just checking in. I think we've had a problem with one of our speakers.
Yeah, I've emailed. Sorry, Aparna. I've emailed them again, but had no reply. So I'm not quite sure what's happened to Zethu. But
I think if it's all right with colleagues, my understanding was the reason why the team wanted to come and speak to us. It was an issue with the way that perhaps GPs are making the referrals. So I think that they wanted to introduce their referral form to us, which I think that they've updated. So perhaps we can share that with the newsletter.
Yeah.
Laura?
Sorry, I missed. Who was it? Who was supposed to be coming to speak to us about which referral pathway?
Zethu Mekatini.
No, but which service? Sorry.
Oh, for the memory clinic.
Ah, okay. Another thing, again, I'm just going to spout off what we should already know, but also was pushed again in the LMC conference yesterday as well. I just have to remind everyone that, yes, referral forms can be useful, but we don't have to use them. If we think a detailed letter is better for us to write and it's got all the relevant information in it, we don't have to use a form sent to us by a certain service. So I just want to remind everyone about that. Sorry.
Okay, thanks, Laura. Sorry, I'm laughing at Anil's comment. Okay, so that's fine. I think I think that we'll get a few minutes back. So is there any other questions or anything that anybody wanted to ask while we're all together? No? So, okay. So happy Father's Day to those of you that are celebrating on the weekend. And I hope everybody has a good week, and we'll see you at the next webinar. Anil, sorry, you've got your hand up again. Did you want to come in?
Just really quickly, it might be useful if we could maybe look at palliative care services locally, and whether we can get the new consultant who's suddenly decided to make a new decision not to help and support us with the MAR charts in primary care. Because I know for me specifically, I've done a palliative care job for a whole year, but this was again 15 years ago. So therefore, to keep my skills really up to date, to know exactly what medicines to use and when to use them, and if we're not using on a regular basis, we do struggle. And it's always been the CSN and the specialist nurse who's done the MAR charts for us, really supported us with it. So suddenly to turn around to practice and say, you got to do it yourself, as senior GPs, people are going to come to us to look for guidance, and we ourselves don't know sometimes. So where is that? Is there a gap in the service? And if it is it something we need to look at for the contracting model for April next year, where our local SNSs can incorporate? Because it does take a lot of time and effort to work out the medication doses, which are very tricky to do, and then transfer it to the MAR charts. The MAR charts only last for 2 weeks. You need to be updated on a regular basis. If we were to delay in primary care and not provide it, the patient would go without, because a district nurse would not be able to administer. So there's a few other nuances that we really need to tie out and understand it now. And our lovely Dr. Sheetal's raised it as a real concern. So please, if we can look at that somehow.
We will note it, Anil. So I think, Karen, we can ask that. I've forgotten the consultant's name already.
Dr. Lucy, I think something, yeah.
Lucy Qureshi. So if we can invite Dr. Lucy Qureshi to discuss, because I think these changes have been made, but there's not been any communication.
Yeah, and I don't know if it's appropriate, but we could potentially reach out to the local hospice, which is St Joseph's or others, if you want a slightly bigger capture, or you just want palliative care consultants.
I think she's the new consultant for St Joseph's, Karen. Yeah, I think she's the new consultant taking over there. But it would be good if we can have a look at the other ones. There's one in Havering, for example, and the other ones locally. What do they do to support their local clinicians? Wonderful, thank you.
Thanks, Anil. Laura?
And just before that meeting, it's probably useful for everyone to be clear about what we are contracted to do and not, because it's all good and well if they come along and go, oh, we thought you're supposed to do it, we thought you're supposed to do it. Let's get that clear before that, and then it'll be more fruitful.
Great, thanks, Laura. Good point. Okay, good. Anything from anybody else? No? Good. Okay, everybody have a good weekend, and we'll see you at the next webinar. Okay, take care. Bye.
Thanks, bye-bye.
So Anil's on his Ferrari and Dr. Sen on his Brompton bike, I think.
No, so I think, Karen, there are a few things that have been picked up, because I think the immunisations, all the practices do the travel injections differently.
Yeah, and I mean, we could potentially support that collective comms if we think that's useful.
I mean, I always think it's useful, because we have the odd patient that will be like, oh, well, my friend at such and such practice, they gave them to them the day before, whereas I might say no, like, you know how Anil said that they need to take them 6 to 8 weeks before. That's the stance that we carry. But I might look at Anil's website as well to see what he's got on there, because he said he'd put something up there.
Yeah, I mean, it might take a little bit of time, but even just having a capture, because I think some practices would, if they saw, you know, the generic was 6 weeks, then they could kind of consider whether they want to adopt that approach and feel that strength in numbers, isn't it? Sort of thinking. So a convertible mini. Well done, Anil. And certainly I'll reach out to St Joseph's, and maybe also the Havering, I've forgotten the name of the Havering hospice team, and just see what we can do in terms of palliative care. That feels
because I think the
one.
palliative care one, I think, is an issue, and I think that the reason why Anil raised that is, so Dr. Sheetal Shah raised it in the GP group, where she was saying that the new consultant has told all the palliative care nurses that it's the GP's responsibility to do that prescribing.
Right.
And I think
that's
that
Dr. Lucy
Anil quite
Qureshi.
rightly,
Yeah.
quite rightly said that it's not, you know, I did it when I was working in the hospital, and when I was asked to do one recently. When I say recently, it was last year, and it took me more than half an hour to do it. I emailed it, and then I was told it needed to be a hard copy with a wet signature. And then in the end, I just asked the consultant to do it for me. But if we're being expected to do that, I think we need to find out what we're supposed to be doing contractually as well. I think points well raised.
Absolutely, and you definitely don't want to leave yourself exposed in terms of people's end of life care. So no, absolutely no problem. I'll happily reach out to St Joseph's and St Francis. So thank you. That'd be good.
Okay, good. And I think, you know, with the speaker that didn't join us, I think what we can do is, my understanding was that there was some issue with the way that the GPs do the referral. So if it's just that they want to share the form, we can do that. If not, what we can do, if they do want to still present, we could get the clinical lead to do a bit, and then they come in with the service.
Yes, that's nicer,
you know,
isn't it? You get a more comprehensive pickup in terms
of like a bit of teaching and then the service.
Perfect, no problem. I'll reach out to them. I mean, I have emailed them. They were confirmed, but things happen, don't they? So I don't know quite what's happened. And I did email them in the forum, but obviously, if someone's had a emergency, they possibly haven't had an opportunity to let us know.
No problem. Okay, thank you.
And I'm sorry, I lost the. I don't know why I completely froze. Couldn't change anything. Couldn't speak.